next we move on to the session on prescribing psychiatric drugs in primary care. And I would like to cordially invite Dr. Mahesh Rajasuriya to the head table. Dr. Namal Ulisheba will introduce Dr. Mahesh Rajasuriya.
On the behalf of College of General Practitioners of Sri Lanka, it is my pleasure and honor to welcome today our expert resource person, Dr. Mahesh Rajasuriya. Dr. Mahesh Rajasuriya is a senior lecturer at Department of Psychiatry, Faculty of Medicine, University of Colombo, and a consultant psychiatrist at University Psychiatric Unit of National Hospital, Sri Lanka. He is a member of the Expert Committee on Tobacco, Alcohol and Illicit Drugs of Sri Lanka Medical Association and founding director of the Center for Combating Tobacco at Faculty of Medicine, University of Colombo, and the chairman of Alcohol and Drug Information Center and vice patron at NEST Sri Lanka. He is going to take us on prescribing psychiatric drugs in primary care. Please.
Thank you, Chair, for the kind introduction. Since you're already behind time, I think we'll get on with the topic straight away. So I'm going to talk about conditions that you can manage in the general practice in primary care, medications to use, cautions and pitfalls you need to keep in your mind, and the networking and shared care that you can get involved in. So these are the conditions that I thought of to list up and discuss: substance use, schizophrenia and psychosis, depressive disorders, bipolar disorder, OCD and other anxiety disorders, dementia, stress, anxiety and adjustment issues. So all of them are not psychiatric disorders as per se. Sexual dysfunctions and deviations, sleep disorders, aggression and anger issues. So stress, anxiety and adjustment issues does include anxiety towards exams. It is a major condition I think doctors have to treat or to help with. If there are any suggestions that any other condition has to be included, I can even do it now and discuss about them. So if you have any, I don't know whether the viewers have a way.
We have a Q&A session
right,
after
okay.
that. Yeah.
So you can suggest any, even you can send messages now, so if I can get the response, I can save time for that. Okay, so let's start with substance use. So the initial few conditions actually take more time and rest less. So substance use, we are going to talk about alcohol how to manage, how to prescribe, not how to manage, right? How to manage is a big topic. So this is about prescribing, right? But I will add a little bit of management as well, but it's mainly prescribing in alcohol withdrawal, opioid withdrawal, nicotine withdrawal, cannabis withdrawal, other withdrawal states, and how to stop use of, how to help patient to stop use of the substance. So let's start with alcohol withdrawal. So you know that in alcohol withdrawal, I try not to spend time on, explaining the disorder, the condition and the pathophysiology and all that, because that's not the scope of my presentation today. But you need to have some basic idea. Alcohol withdrawal is where, the CNS has gone into a hyperexcited state, right? Because alcohol is a CNS depressant, as you all know. So the patient's brain has been chronically depressed by alcohol. So the brain has been fighting to be non-depressed, to be excited. So a lot of glutamate and less benzodiazepine receptors in the brain of the person who chronically use heavy dose of alcohol. So the moment the alcohol is stopped, suddenly there is very little GABAergic or depressive activity, and there's a lot of excitatory or glutamatergic activity. So the brain is hyperexcited. So you need CNS depression. What we need to do by prescribing, what you are going to do is to depress the CNS. I mean, the obvious alternative is to give him some alcohol, and it depresses the brain and the person is fine. So how to do that? Then the person who uses alcohol like this is usually not very good, or not maintaining his nutritional status. So usually they are in thiamine deficiency. So you need thiamine supplementation. So these are the mainly prescriptive needs. I mean, you need nursing care, you need to educate the patient, you need to help the family, hydration. There are so many things that are important, but as per the topic given to me, I'm going to talk only about the CNS depression and thiamine supplementation that we are going to do. So obviously, what we are going to use are, for CNS depression, benzodiazepines. So we know that very well that benzodiazepines they do depress through GABA receptors the brain. So you feel sleepy, you feel calmer, you feel sort of not very active, and then you might actually fall asleep. So benzodiazepines, I think the evidence is accumulating that diazepam is perhaps the best option. Although we traditionally use chlordiazepoxide in hospital settings to treat alcohol withdrawal, diazepam seems to be much better and available. But from time to time, suddenly in the market, diazepam is not available, and on another time, chlordiazepoxide is not available. So don't worry, anything that is available is fine. So diazepam, chlordiazepoxide, but if you want a shorter acting medication, especially if you think the patient's liver functions are quite damaged and might not, what you fear is this: you give benzodiazepines, patient goes into a deep coma and then suffer the complications and encephalopathy and all that. So then you need to quickly stop benzodiazepines, or before going into a deep coma, patient is unduly sedated, so you want to stop the benzodiazepine. But if you stop a benzodiazepine with a long half life, the effects are not going to be reversed quickly. So if you are suspicious of that, use lorazepam. But diazepam again is generally well tolerated even by the one who has poor liver function. So you don't have to worry too much unless the patient is in serious liver failure. And the doses, diazepam, you can, it depends on the amount of withdrawal symptoms the patient is going to have. So it's very difficult to give a rough formula. But if the patient is using, say, a quarter of a bottle of spirits every day, the dependence is not going to be very, very bad, but it's probably dependence. But if it's going to be half a bottle, of course the dependence is going to be serious. If it's going to be more than that, dependence is the withdrawal dependence is severe, and withdrawal is going to be very, very bad. So somebody is taking, I mean, these are very, very rough estimates, not for MCQs. So for somebody who's taking maybe a quarter bottle a day every day, if somebody is not using alcohol every day, it's very unlikely the person is dependent, right? At least 5-6 days a week the person is using, if person is dependent, right? So you can give diazepam maybe 5 milligram 3 times or 10 milligram 3 times maximum. If you feel like you need to give that's a big dose, by the way. In normal conditions, giving diazepam even 5 milligram 3 times a day, we would sleep for days. But these people are tolerant because they can tolerate a lot of alcohol. There is cluster tolerance between alcohol and the benzodiazepine, so they can tolerate a lot of benzodiazepines, although they have never taken a benzodiazepine, right? This is called cross tolerance. So don't worry, don't be afraid. You can give a fairly high dose. Most likely you will give a lower dose than needed. So diazepam, chlordiazepoxide, slightly higher dose, maybe 10 milligram 3 times a day or 20 milligram 3 times a day. Lorazepam 1 milligram 3 times a day, or maybe 2 milligram 3 times a day, or 4, 5. I mean, there is no upper limit. Somebody who's taking 1 bottle every day might need diazepam 20 milligram 3 times a day, or 30 milligram 3 times a day, or even more than that, right? If the patient cannot sleep, if the patient cannot calm down, if the patient is trembling, you need to give more, right? But you are not going to manage such a patient in the primary care or the GP practice, right? It's very, very dangerous. There are so many complications that come along with severe alcohol withdrawal. It's a medical emergency, can kill the patient. So unless it's a fairly mild withdrawal and the patient doesn't want to go into hospital, you would do it, right? Okay. So if I were managing a patient in the outpatient, as an outpatient, my dose would be diazepam 5 mg TDS, maximum 10 mg TDS, right? Maybe another 10 mg in the night if you can't sleep. If you feel like you need to prescribe more than that, better to get the patient admitted to hospital. However, if the patient refuses to get admitted to hospital and he's going to anyway do it with your help or without your help, he's going to anyway stop alcohol, then take a chance and, don't give a high dose because you might get in trouble, that prescription if seen by somebody. Right, thiamine, you have they have severe thiamine deficiency. Polybion is useless. There's no point in giving polybion or multivitamin or anything. So you have to give either generic thiamine tablets or vials, parenteral. It's about 100 milligrams a day what they need, at least for 5 days, right? But better for a couple of weeks. 100 milligrams a day. So you can give thiamine tablets, and there are 10 milligram tablets in the hospital. Then you have to give 10 tablets of that. But then there are Neurobion. From the trade products available, it's Neurobion, Neurobi, or Pabrinex. Others are useless. There's no point in giving them, right? Right. So diazepam you can give until the symptoms subside, usually a week, and you have to gradually start tailing it off after the second or third day. But if you can, if it's difficult to get the patient down that frequently, you can ask the patient to come in 1 week and ask the patient to cut down the amount in 3 days, and then when you see him in 1 week, then you can further reduce and stop it. Cautions and pitfalls. The usual pitfall is that you are not giving enough benzodiazepines and the patient is severely agitated, distressed, and would probably go and drink alcohol or get admitted to hospital, which is also not a bad outcome. Oversedation is unlikely, overprescribing, but give this advice. If the patient is sleeping, do not give the next dose. Right? If the patient is sleeping at home, you don't have to wake up for the after lunch dose and give it. If the patient is sleeping, skip that dose. And there are unrelated complications. It's not the diazepam, it's not the lorazepam. The patient has a serious liver problem. Patient was about to develop a myocardial infarction, and your hard luck, the patient develops myocardial infarction next day, and you will be blamed for the diazepam. And patient dies, right? They will say that Dr. Dunna behed leda mala, right? So be careful. So if you are giving a serious dose, you have to have either some sort of senior cover or hospital admission. So indications for inward detoxification: if the patient has had seizures, alcohol withdrawal seizures, delirium tremens, patient is delirious, disoriented. You need to admit the patient. If there's nobody to give the medication properly, if the patient is unlikely to take the medication properly, try to admit. If there are any other complications like liver disease, serious, significant, I would say significant, and any other comorbidities, if you are not sure about the patient's general health, admit. Thiamine, actually, you don't have to worry too much about cautions and pitfalls. Remember to give it, because if you don't give it, the patient will develop Wernicke-Korsakoff, Wernicke encephalopathy initially, and then later Korsakoff. So it's very easily prevented. They end up in dementia. So it's very easily prevented by giving thiamine. So don't forget to give it. That's the pitfall, actually. There's nothing in giving it. Opioid withdrawal, there is a symptomatic treatment. They have insomnia, aches and pains, diarrhea, rhinorrhea, and lacrimation. These are the main symptoms that you can treat with medications. So you can give, for insomnia, give something like olanzapine. Do not give benzodiazepines. I'll tell you why. Aches and pains, diclofenac, diarrhea, loperamide, 2 milligram 3 times a day. Rhinorrhea and lacrimation, you can give something like clofenramine or promethazine, antihistamine. Sedative, better. Again, these symptoms also last for about 1 week. So you can prescribe for a week and ask the patient to come back in a week. And then you don't have to really tail off like in benzodiazepine alcohol detoxification. You can just stop, or you can give for another week and see what happens. Cautions and pitfalls. Why I warn you against giving benzodiazepines and other hypnotics like zolpidem. There's a huge black market for these medications. So many of your patients are actually not patients. They have come to get a prescription to get clonazepam, to go and sell it, right? So, well, you can make money if you talk to the patient in the right way. So please don't get into that. And they can get addicted to benzodiazepines, or they will have tolerance because they may have already abused benzodiazepines, and you give 10 milligrams of diazepam thinking, this guy will now sleep. He won't sleep. He won't even feel it because it's not enough for him. So olanzapine, people don't abuse olanzapine or chlorpromazine, some antipsychotic, right? They will most likely sleep well with that medication, and olanzapine doesn't give rise to things like extrapyramidal side effects, so you are fairly safe. Otherwise, there can be acute dystonia or whatever. Do not give or try not to give pregabalin and tramadol. Again, a huge black market. They are coming just for the prescription, and they will start abusing. And doctors are responsible for the pregabalin and gabalin epidemic in Sri Lanka. Methadone, again, not widely available in Sri Lanka, so we don't want to introduce just another pregabalin, right? So try not to give methadone. And there's a significant risk of death with methadone because methadone is a full potent opioid agonist. It's like heroin. And heroin is black market, adulterated. It's not pure in Sri Lanka. It's not clean, right? So when they think that they are taking 100 milligrams, they are not taking 100 milligrams. But if you give methadone, it's full dose. And it's overdose for most of our patients. And respiratory depression, and patient will die. So methadone can kill the patient. Heroin withdrawal will never kill a person. Alcohol withdrawal can kill a person. Alcohol withdrawal can kill a person. Delirium tremens, alcohol withdrawal seizures can kill a person. Any other withdrawal will never kill a person. But methadone can kill a person. So be careful of that. Nicotine withdrawal, much less problematic than alcohol or heroin withdrawal. Medications are hardly needed unless it's a very severe, like somebody who smokes 20, 30, 40 cigarettes a day, like a chain smoker. Then the person is going to be in big trouble. It's very difficult. It's not easy, but again, not life-threatening. So you can advise the person to gradually cease and stop rather than abruptly stop. So then withdrawal symptoms are, not that difficult to tolerate. You smoke 20 cigarettes a day. Why don't you 18 next day, 16 the following day, 14 the next day? You can gradually cut down, and then you don't need any medications. If you are giving nicotine replacement therapy, use it like benzodiazepines in alcohol. For those with most severe withdrawal, there are skin patches which are very expensive, lozenges which are much less expensive. 2 milligrams, 4 milligrams, 6 milligrams, you can try and, give it, you can give a dose or two and see how the person, how much relieved, and then give next. And try to, tail it off and stop it within, again, a week or less than that. However, that's needed only by a very handful, just a couple of patients that you will come across. Generally, NRT is not needed, although it's hugely promoted as a wonderful essential. WHO has classified it as an essential medication. Who is behind this is the tobacco industry. They are producing NRT. So can you imagine tobacco industry producing their own cure? If it is effective, they will never do that, right? They market NRT. So NRT is not a dream drug. Don't rely on it. But if somebody is severe, and somebody who wants to, fly, who is severely dependent on nicotine, but he doesn't want to stop nicotine, but he has to fly and he can't smoke. So you can give NRT for the duration of the flight. Otherwise, you can give symptomatic treatment like benzodiazepines and amitriptyline, because it's mainly anxiety that they have, irritation, anxiety when they are in withdrawal. So you can give a bit of benzodiazepine. Nortriptyline is supposed to work well, but nortriptyline is not available in Sri Lanka. So we assume amitriptyline might, because closely related, it might do the trick. Cannabis withdrawal, even less problematic. Some patients don't even notice that they have serious withdrawal symptoms. If they complain of insomnia or whatever, you can give a bit of olanzapine or, treat symptomatically. Other drug withdrawals are not usually a major problem, because mainly the other remaining drugs are the stimulants, amphetamines and cocaine, right? Ice is methamphetamine, right? These are stimulants, so when you take them, you can't sleep, you are up and alert and all that, so you can't chronically use them. I mean, you will use them for 1 day, 2 days, 3 days, usually party and next day they don't use it. But even if you use it every day, I mean, you can't go on without sleeping for days. So one day you forget to take it and you sleep for 3 days at a stretch, like a hangover, right? So you don't usually chronically use these medications. So practically you don't come across of with ice withdrawal or whatever. Remember, not to be manipulated by the patient. There are patients who come and tell you, doctor, the previous doctors have been very bad, give me the right perfect medication, I know you would do it. And gullibly you would say, I know now what to give and I will give the right medication, and you give it. No matter what you give, the patient next day says, or the family comes and says, he said that it didn't work and he is using again. This is excuse not to stop. There are people who do not want to stop. They are not motivated, but they will need to trick the wife or the mother or somebody that they are committed. So they come and tell you, give me the perfect medication, I will stop. Whatever you give, it's never perfect. So next day they say, this is not good enough, I am using again, that's a useless doctor. So your image is tarnished. So do not get into that trap, right? So tell them, this is not 100%, this is not magic, right? So you have to put in an effort as well. If you can't put in that effort, no matter how much or what I prescribe, right. And finally on substance use, how to prevent or cease or help the person to reduce the use of alcohol, opioids, nicotine, cannabis and other drugs. That's in the longer term. So withdrawal is 1 week, finished, done, and you want to make sure or help the person to not to use alcohol again, or to use less alcohol hereafter, or after 6 months or whatever. So there are there are so many other effective psychological and psychosocial treatments, which is not my topic today. Medications, what can be used to prevent alcohol use? Aversive, the disulfiram, and the anti-craving, naltrexone and acamprosate. So disulfiram, we have 250 milligram tablets, naltrexone 50 milligram tablets, acamprosate 333 milligram tablets. You use 666 3 times a day, acamprosate. Naltrexone about 50 milligrams a day. They can be taken even when the patient is using alcohol, but disulfiram, no. Patient has to be at least 24 hours free, completely free of alcohol to start disulfiram. And when you're on disulfiram, you cannot use alcohol. You have to stop disulfiram, wait for 48 hours, and only then you can use disulfiram, alcohol again. So these medications can help. Disulfiram you can give for 6 months, so maybe even 12 months, and then stop. Right, the cautions and pitfalls. Disulfiram, there's a serious reaction between disulfiram and alcohol, so you have to warn the patient of that. Actually, that warning is the one that works, not disulfiram, right? So I cannot take it. If I take it, there will be severe reaction to it. So don't give without telling, and you will be held responsible if something happens, right? So you tell, and if the patient is ready to take it, that means the patient is motivated actually. So there's a high chance that you can actually have good results. If not, tell the patient, tell the family, see, this man is not interested. He doesn't want to take this medication. So that means he's not properly motivated, well motivated, so I can't help him at this stage. Why don't you put more pressure to him and bring him to me next week, and then I will give the medication. The medications for prevention of use of nicotine, opiates and cannabis have very poor evidence, so I'm not going to talk about them. And remember, stopping the use of the substance is but one outcome that is desired among many. If the person beats the wife, that has to stop. If the person doesn't give money for the children's education, that has to stop. So among all these, one is stopping the use of substance. Don't think just because somebody stops using substance, all the problems will disappear. That doesn't happen that way. Okay, so let's move on to schizophrenia and psychosis. Mainstay of treatment is antipsychotics. The main objective is to suppress an episode or to prevent the next episode. So somebody is psychotic, you give antipsychotics to make him better, well, and then you continue the antipsychotic to prevent the next episode. So we have two kinds of antipsychotics: first generation, the older ones, and the second generation, the newer ones. The first generations, the best one in my opinion is trifluoperazine, and then haloperidol and chlorpromazine. Never give chlorpromazine parenterally; it can even kill. So IM, IV, never give chlorpromazine. I mean, I don't think you have to do that in primary care, but remember that never ever give chlorpromazine parenterally. And you have depot injections: fluphenazine, flupentixol, zooklopentixol. Every 2 weeks is the best frequency, or maybe every 3 weeks, or maybe every 4 weeks. And there are lots of GPs who are managing patients who have severe problems with compliance, with huge risks on depot injections in the community very well. Second generation antipsychotics: risperidone, olanzapine, ariprazole, quetiapine, ziprasidone, amisulpiride. And the special medication is clozapine, which is given for resistant schizophrenia. And there's another army of general practitioners who are managing patients who are on clozapine, who are now stable, right? You have to do white blood cell count every month and make sure that the white cell count is more than 3,000 and the neutrophil count is more than 1,500. And every month you have to send the patient to the psychiatrist for the annual review. And clozapine is a wonderful drug. Many people doing very well on clozapine. Be very careful. The pitfalls, the cautions and pitfalls. First generation antipsychotics not very fashionable. So if you prescribe a first generation antipsychotic, others might laugh at you saying that you are old fashioned. The latest generation says the first generation antipsychotics works as much as second generation antipsychotics. So there is no, I mean, previously the recommendation preferences start with second generation antipsychotics. It's no longer the recommendation. You can start off with first generation if you are going to. Otherwise, some psychiatrists may give first generation antipsychotics as the first line treatment. That is the latest evidence. Metabolic syndrome is the big problem with second generation antipsychotics. You have weight gain, blood pressure going up, cholesterol going up, blood sugar going up. So they don't have these extrapyramidal symptoms, but they have a lot of metabolic symptoms, side effects, which actually kill the patient in the end. And be careful about the wrong diagnosis. Starting an antipsychotic is a major decision because it's most likely going to be continued forever or for long times. So be very careful about the diagnosis. Depressive disorders. So again, you need to suppress the current depressive episode, and you have to prevent the next episode. So the main medications are SSRIs, selective serotonin reuptake inhibitors, SNRIs, selective serotonin and noradrenaline reuptake inhibitors, and others. There are minor variations, and tricyclics, the older ones. So SSRIs are fluoxetine, sertraline, paroxetine, fluoxamine, and some more. SNRIs and others means mainly what is available in Sri Lanka is venlafaxine and mirtazapine. Venlafaxine is non-sedative, mirtazapine is sedative. Mirtazapine is very, very sedative, but it can make the patient gain weight as well. SSRIs and venlafaxine, they sort of reduce the appetite. But mirtazapine is fairly safe with other medications. Somebody who is on a lot of medications, others are also not too bad, but mirtazapine is safer. Tricyclics, the older ones, imipramine, clomipramine, and amitriptyline, are quite effective. The problem is that they are very, very toxic, fatal in overdose. So if somebody is going to overdose, try not to give tricyclics, or get a family member to give tricyclics. Cautions and pitfalls. Most of the patients who are diagnosed of depression do not have depression, right? What usually happens, what is wrong is the actual diagnosis is missed. There are so many people out there who are depressed and they are not recognized as depressed, right? There are so many people out there who have anxiety. So there's a big difference between depression and anxiety. Of course, anxiety can coexist in depression, but anxiety is your uneasiness. You are not sure, you don't know what to do, you are uneasy, you are distressed. So anxiety is diagnosed as depression by many doctors, right? Even psychiatrists at times. And distress is diagnosed as depression. You fail an exam and you diagnose depression. No, that is distress, right? So antidepressant won't help, but it will help in a way, I'll tell you. And these SSRIs and SNRIs can give sexual side effects in males. So you have to be careful. Tricyclics do not give sexual side effects as much as the others do. But the toxicity of the tricyclics is the problem. Right. I don't know, I was told for a 45-minute session, or if we need to. 30 minutes for the lecture. And the question. All right. Okay. All right. Okay. I'll finish bipolar disorder and rest maybe we can do as question and answers. So in bipolar disorder, you have depression and mania episodes. So you need to suppress you need to suppress mania when they have it. But when they do not have it and when they are in remission, you need to prevent the next mood episode, be it depression or mania. So to treat the mania, to suppress the mania, you give antipsychotics and you give mood stabilizers. All work, antipsychotics work, which we discussed previously. Lithium, valproate, carbamazepine, lamotrigine. These are the main. The most widely used mood stabilizers are lithium and valproate. Cautions and pitfalls. Lithium, if you may be managing patients who are on lithium, you have to be very careful. Sometimes the psychiatrist may not be that careful, but you have to be careful because it has a narrow therapeutic index. It can be toxic, so you need to do monitoring, preferably 3 monthly, at least 6 monthly, do a serum lithium level. It has to be 12 hours after last dose. And it can have interactions. NSAIDs, don't forget NSAIDs. If you are giving regular NSAIDs, you have to be careful. You have to do lithium levels. Try to avoid NSAIDs. Diuretics, ACE inhibitors, antibiotics, they all can interact with lithium. So, bit of a headache managing somebody who is on lithium, but it's a very, very effective medication. Other mood stabilizers are not that difficult to manage, but somewhat less effective. Valproate, but remember, valproate can rarely give rise to hepatitis and even pancreatitis. So keep that in mind. So these are acute side effects; they are not chronic. Lithium can give rise to many chronic side effects like tremors, dry mouth, and drinking a lot of water because of that and that sort of thing. Lamotrigine can give rise to skin rashes. Carbamazepine can give rise to Stevens-Johnson syndrome. Okay. So those are the main, the big chunks which I have. I actually thought that the whole 45 minutes for the presentation, so I prepared like that. So we can quickly discuss the other things, or maybe I will wait for some questions. So maybe if I need to change the, trajectory, I can do that now. There are some questions.
There are several questions raising from the online participants. There are several questions raising from the online participants. First one, how useful hypnosis in prevention of the alcohol dependence?
Okay, not very useful. The short question, answer. Hypnosis is suggestion. There are much more effective treatments than hypnosis, but hypnosis works for habit problems. Alcohol is more than a habit, so no. The quick answer is it's not very recommended.
The next question, please talk about drug prescriptions in mental retardation, psychosis and depression. I think we already discussed the psychosis, depression, and you have
In the mental retardation, you are more predisposed to develop psychosis and depression, people who are with mental retardation, but the symptoms may not be very clear, so you might have to sometimes suspect and give the medication. Start with a smaller dose. That is the main message.
Next one, what is the difference between aversive and rarings?
The aversive treatment and the anti-craving. Aversive is, disulfiram, the patient knows that there is going to be a big problem if I drink alcohol, or a patient actually drinks alcohol and there's a reaction with disulfiram, headache, flushing, all that. So that is aversion. Because of that, you will never drink alcohol again, or you won't drink alcohol for some time. That is aversion. Anti-craving is that you have a compulsion inside you to drink, go drink alcohol. So that is somewhat reduced, not magically, that is somewhat reduced by the anti-craving medications.
That's only we received. Any questions from the audience? I think it seems no more questions. Then very much thankful to Dr. Mahesh Rajasuriya for your informative and very interesting lecture. Now we are going to conclude the session. Now I am inviting to my co-chair, Dr. Kalpani, to hand over the token of appreciation.